Hey everyone, and welcome to this explainer. If you're a university student, whether you're in medicine or dentistry, you are in exactly the right place today. Look, we completely get it. Infective endocarditis can feel like this massive, overwhelming wall of diagnostic criteria and microscopic bugs that you just have to blindly memorize. But consider this your ultimate, high-yield masterclass to cut through all that noise. We're going to break down the complex pathology, the classic clinical clues, and the exact clinical guidelines you need to know. Not just to absolutely ace your university exams, but to safely and confidently manage your future patients. So let's jump right in. Here's our roadmap for today. First up, we'll answer what is infective endocarditis. Then we'll cover acute versus subacute types, move into the classic signs and symptoms, tackle diagnosing with the Duke criteria, and wrap up with treatment and dental prophylaxis. We've got a really clear, structured breakdown here, and it perfectly mirrors how this stuff is taught, and more importantly, how it's tested. Trust me, understanding this structure is the key to unlocking those tricky exam questions.
All right, part one, what actually is infective endocarditis? Let's lay down our foundational concept before we even think about diagnosing or treating it.
So at its core, infective endocarditis is a microbial infection of the endothelium of the heart. And most commonly, this happens right at a site where the endocardium is already damaged. Now, the absolute mega keyword for your exams here is vegetation. Think of a vegetation like a microscopic fortress. It's made up of platelets, fibrin, and microbes. When the endothelium gets damaged, maybe from a high-pressure jet injury in valvular disease, it invites platelet adhesion and fibrin deposition, because your body is just trying to heal itself. But then, bacteria enter the bloodstream, they hijack that exact spot, and they hide inside a fibrin shell. That shell is literally a physical shield against your body's immune system, which is exactly why this disease is so notoriously difficult to clear naturally.
Moving right along to part two, acute versus subacute types. Examiners absolutely love to test if you know the critical, life-or-death differences between these two classifications. And here is the classic divide. On one side, we've got acute IE. Think of the bacteria here, usually Staphylococcus aureus, as a completely violent home invader. It is highly virulent, rapidly progressive, and it can literally kick the door down to attack and destroy completely normal, healthy heart valves. It acts super fast, and without immediate treatment, it's fatal. On the flip side, subacute IE is more of an opportunist. It takes a much slower, indolent course. It's usually caused by the viridans group of streptococci, which, normally just live peacefully in your mouth and upper respiratory tract. Because they're less aggressive, they typically only settle into valves where the door is already broken, meaning valves structurally damaged from past traumatic fever or maybe a congenital defect.
Okay, part three, classic signs and symptoms. Now that we know what's happening inside the heart, let's look at the outside. This section is packed with high-yield eponymins you absolutely must memorize. Remember those vegetations we talked about? Well, because they're sitting right there in the raging river of your bloodstream, little fragments can easily break off as tiny emboli and travel, honestly, anywhere in the body. That makes this a highly systemic disease. You're going to see general prodromal stuff, unexplained fever, drenching night sweats, weight loss, along with direct cardiac signs like a brand new murmur. But for the exams, it's the peripheral signs. The really strange things showing up on the skin and in the eyes, that's where the test questions live. So, quick pop quiz to test your active recall. If an attending physician asked you right now, where exactly on a patient's body would you look to find a Roth spot? Do you know it? If you said the retina of the eye, you nailed it. Roth spots are white-centered retinal hemorrhages caused by immune complexes. Now, if you only remember one single thing from this whole explainer for your board exams, make it this list. Here's your cheat code. Osler's nodes are painful. Remember O for Osler and O for ouch. They're tender, raised swellings on the fingertips. Contrast that with Janeway lesions, which are totally painless, flat spots typically on the palms and soles. Add in splinter hemorrhages, those tiny dark lines under the fingernails, and boom, you've got the classic peripheral manifestations perfectly memorized.
Spotting symptoms is one thing, but part four is all about proving it. Diagnosing with the Duke criteria. This is arguably the most heavily tested area in all of IE management.
I know, the Duke criteria can look like this incredibly intimidating wall of text. Actually, scratch that. It looks like a giant puzzle based on clinical, lab, and echo findings. But don't stress, we're going to simplify this right now into categories that actually make logical sense.
They split neatly into major and minor criteria. Think of the major criteria as your absolute smoking gun.
You need persistently positive blood cultures proving the exact bug is currently swimming in the blood, and you need an echo showing the actual physical damage, like a wiggling vegetation or a new regurgitation. The minor criteria? That's your circumstantial evidence. A fever, a predisposing heart condition, IV drug use, or those vascular and immune phenomena we literally just talked about, like the Janeway lesions and Osler's nodes.
So, how do you combine all that for a definitive diagnosis? Just memorize these numbers. Literally, lock this into your brain. You need 2 major criteria, or 1 major plus 3 minor criteria, or 5 minor criteria. That exact numerical combo is pure rote memorization gold for your exams. You are definitely going to be asked to calculate a patient's score on a clinical vignette.
All right, final section, part 5. We've got the diagnosis. Now, how do we treat it and how do we prevent it? Dental students, you're going to want to pay very close attention here.
Treatment has got to be incredibly prompt. Let's walk through the logic. Step 1 is absolutely non-negotiable. You must draw 3 venous blood cultures from different sites, spaced about 30 minutes apart. Why? Because you have to do this before you start antibiotics. If you don't, you might sterilize the blood, miss the smoking gun, and never identify the bug. Step 2, start empirical IV bactericidal antibiotics. Remember that microscopic fortress? Since those vegetations don't have their own blood supply, your immune system can't really reach the bacteria hiding inside. So you need massive serum concentrations of aggressive drugs, like ceftriaxone and gentamicin, or vancomycin. Step 3, once the lab identifies the exact bug, you adjust the drugs. This therapy is grueling, often lasting 4 to 6 weeks, just to make sure the medication fully penetrates that vegetation. But sometimes antibiotics just aren't enough. Sometimes you need a cardiac surgeon to literally save the patient's life. This is a dramatic escalation, and you have to know these surgical triggers. The big ones are severe heart failure due to catastrophic valve damage, massive vegetations on left-sided heart valves that pose an imminent risk for a stroke, burrowing abscesses right in the heart tissue, or if the endocarditis is caused by a fungal infection, which pretty much never responds to just medical therapy. Let's finish up by hammering home dental prophylaxis. The guidelines have changed a lot over the years, and examiners want to know you have the latest updates. Antibiotic prophylaxis is no longer recommended for routine cleanings in average healthy patients. It's only for patients at the absolute highest risk. Who are they? People with prosthetic heart valves, a previous history of infective endocarditis, or unrepaired cyanotic congenital heart defects. And they only get it before dental work that involves manipulating gingival tissue or causing bleeding. Get this, though. The source notes that everyday chewing and brushing actually exposes the heart to way more cumulative bacteremia than a single dental visit. Crazy, right? So, we've covered the destructive pathology, the specific bugs, the Duke criteria, and the intense treatments. But I want to leave you with this provocative thought as you head back out to the clinic or the library. Knowing just how incredibly fast virulent bacteria can permanently destroy a healthy heart valve, are you confident you could spot the difference between a painful Osler's node and a painless Janeway lesion on your very next patient? Keep that image and that O for ouch mnemonic sharp in your mind. Thanks for hanging out with me for this explainer, and good luck with your studying.